Hi everyone, this is Neel Raithatha, consultant audiologist and director of earwax. Thank you for joining me in my latest video. Had a really interesting day. We've had at least 3 patients I think today with really complex ears, probably some of the most complex ones I've done this year. So I will upload those over the next few days, but I wanted to upload this one today. And this is of a patient who attended with severe otalgia. So otalgia is the medical name given for an earache. And the case history is that this patient has previously undergone earwax removal on 2 separate occasions. The most recent one was yesterday on Boxing Day. The pain was so bad that they called the individual that originally attempted to remove the wax. They weren't able to do it the first time and asked the patient to use some drops. And I think the patient was due to be treated again a week later. But that was only a few days ago. But the patient's pain was so severe that they called a specialist and asked them to do a home visit to try and remove this wax because they just weren't able to cope with the pain. They were taking a lot of painkillers. The patient also, after the second attempt, which the patient felt made their symptoms somewhat worse, the ear became more painful, more blocked. They visited A&E, who advised the patient to book in with their GP. So the patient did have a GP's appointment later on today, so by the time I'm uploading this video, they must have been seen by the GP. But in the meantime, one of their family members actually watches my videos online and recommended the patient come visit me. So they had to travel a fair distance, but we managed to get them in today. And as you can see, this is severely swollen. There's a lot of edema. And posteriorly, and also inferiorly, they've got a build-up of granulation tissue. So I initially tried to use the standard Zollner suction probe, which is a 14 gauge suction tube, which has an outer diameter of 2 to 2.1 millimeters, but it was too big for the patient's ear because it's swollen. Traditionally, I would then revert to an 18 gauge, so it's just a fine end, which has an outer diameter of about 1.28, but that just wouldn't be strong enough for this. Now, some of you may be aware that I'm now manufacturing my own suction tips, and I manufacture them in the full range of gauge sizes from 14 gauge, which is an outer diameter of 2 millimeter, to a 19 gauge, which is a super fine end, which has an outer diameter of 1.05 millimeters. So here I'm using the 16 gauge suction tip, which has an outer diameter of 1.6, and you can see there's just enough space to insert this. But as the procedure continues and as we go a bit deeper in the ear, the swelling is more severe, and the suction tip just about only fits in here. Now, it's pretty obvious that this patient has been poking their ear. We know that because of all this matted hair. These hairs shouldn't be so deep in the ear. These hairs should only grow in the outer third of the ear canal, the cartilage portion. And that's because the cartilage portion of the ear canal, so the outer third, also known as the pars externa, the skin that lines the cartilage has 3 layers. You've got the epidermis layer, so the outermost superficial layer. You then have the dermis layer, which is the middle layer of skin, so that's a thicker layer of skin. And contained within the dermis layer are the hair follicles from where these hair strands protrude out from. And then also underneath the dermis layer, you've got a subcutaneous layer or hypodermis layer, which is essentially a layer of fatty adipose tissue. Now, the inner 2/3 of the ear canal, so this is right in the inner third, the pars interna, the middle section of the ear canal we call the pars media. The skin that lines the inner 2/3 of the ear canal only contains the outermost layer, the epidermis layer of skin. So it's physically impossible for hairs to grow in the inner 2/3 of the ear canal because there's no hair follicles in that region. So this has been pushed in, and the hairs have been matted up against this wax and dead skin. So I'm not sure whether this trauma was caused by the other specialist, or if it was self-inflicted. It may be a combination of both. Now, the patient did advise their pain exacerbated after seeing the specialist again. Now, could be that the patient decided to try and poke afterwards, I'm not sure. But anyway, so this patient has been taking painkillers non-stop, and they were really hoping I could help them. And fortunately, I saw this patient just before my lunch break, which was very lucky because I had a full clinic, and we normally allocate 30 minutes per appointment. Normally that's more than ample time to remove wax from both ears, do all my consent, all my cleaning down, all my clinical notes, any referral letters. But yeah, this patient attended just before my lunch break, which was really fortunate because although you're seeing 30-minute video overall, with all the bits that we've edited and putting drops in the ears, having a chat with the patient who also got very dizzy at the end of the procedure, so I had to make sure they're okay. They were here for at least 55 minutes. So it allowed me to spend some time in this patient's ear, and they just wanted this out. They were really struggling. It wasn't necessarily the hearing, it was the pain and the blockage. And they said to me it's the worst pain that they've ever experienced. It was almost like someone had a screwdriver poking continuously in this ear. And I would say I was a bit... I wasn't sure how well the patient would be able to tolerate the procedure, but they did remarkably well. They were so still. There was no real points where their pain exacerbated as a result of performing the procedure. This is very unusual, because if you're already experiencing pain and then you're having your wax removed, typically you're going to add to some of that pain. But this patient was really, really still and very cooperative. Now, you're probably wondering what this is. Now, this is hydrogen peroxide base drops. Olive oil wasn't really going to do much in this patient's ear. So I had a choice between sodium bicarbonate drops and hydrogen peroxide, and I just decided to use the hydrogen peroxide drops first because this is really deep and you got this swelling. I needed to break up this plug, and it's predominantly skin. Now, hydrogen peroxide, the reason for that bubbling is that hydrogen peroxide is a water-based drops, and the solution that I used was a 3%, and hydrogen peroxide is not typically available in an earwax-based drops in the UK. It was many years ago, but not necessarily now. Instead, what's used in the UK is carbamide peroxide. So carbamide peroxide differs from hydrogen peroxide. Now, hydrogen peroxide is a water-based drops, and the percentage here is 3%. That's what's normally used. I have seen abroad some hydrogen peroxide based drops which is 6%. Whereas carbamide peroxide is a 1-to-1 solution of hydrogen peroxide and urea, and it's kind of in a glycerol base, and probably for me that's the worst type of drops, because the urea turns the wax or dead skin into this mushy mashed potato consistency, which is extremely hard to remove. Hydrogen peroxide doesn't contain the urea, and the science behind hydrogen peroxide drops that it reacts with a catalase enzyme called peroxidase, which is secreted by the ceremonous glands. And when hydrogen peroxide reacts with peroxidase, it converts into water and oxygen. And what the water does, it gets absorbed by the dead skin cells in this plug of wax and skin. And the dead skin cells, they're called corneocytes. They absorb the water, and these skin cells then overhydrate and they burst at the membrane, so you're fragmenting the plug. In addition, so when hydrogen peroxide gets converted into water and oxygen, when it's getting converted into oxygen, you're having this effervescence, you're having this bubbling effect, and it's believed that this effervescence can help mechanically break down the plug, and I was hoping that was going to be the case, and it did somewhat, but not well, it was still very difficult to remove, but it did assist. Now, another reason why I decided to use hydrogen peroxide based drops, because obviously at the moment I'm just seeing this, I don't know what's going on behind this patient's ear. Now the patient, there's no report of a perforation, there's no bleeding, etc., although you can see some blood there at the base of the ear canal, and that was just granulation tissue, which I'll try and explain during the course of the video what it is. But now some ENT do recommend using hydrogen peroxide based drops if a patient has a perforation or a grommet. It's believed to have antiseptic properties because of that effervescence. It can help break up and destroy bacterial cells. Now, when you're using the drops, the instructions say don't use it in a perforation, so that's what we have to follow. But I know some ENT in New Zealand and Australia that actually kind of almost have some instructions for people to make their own solution, and they do advocate it sometimes to use it in if a patient's got an ear infection, for example, the perforation. So that's an interesting thing. So something that probably going to have to see if I can speak to some ENT directly about that and to get some more clarification. So behind this swelling here posteriorly, you can see this plug of skin. It's trapped behind this more aggressive swelling. So it's created an enlarged cavity, a pocket. So we're trying to remove this, which is a wider piece of wax and skin, through a narrow ear canal that exists directly in front of it, which is challenging. And when you've got this much swelling and inflammation, the ear starts to produce more skin cells, and the more skin cells the ear produces, the more dead skin it obviously then secretes, which is then forming into this plug. So it's almost like a vicious cycle. So it did take me a while, and I've used the ear hook I think already. I'm just using the ear pick here, and it was slightly frustrating because I managed to do the difficult thing, which is inserting the ear pick and the ear hook behind this. And I was just hoping as I come away, I'll extract this plug of skin and matted wax, but it just cut through it. Now, that still did help, because by dissecting through it, you're then able to go in with the suction probe and like suction away some of the cutaway parts of this plug. But I was really, really hoping that it would come away. And I am going to use the forceps in a moment. I wasn't sure whether I'll be able to get the forceps into this patient's ear or whether they'll be able to tolerate it, because, of course, with the forceps, although the tip is blunt, it's not a sharp tip per se, but if you don't get something to grab onto, the tip of the forceps can apply some pressure onto the plug, and we apply pressure on the plug. This is already squashed against the eardrum, and obviously it's swollen, so I was extremely worried whether it will exacerbate their pain, but it didn't, fortunately. So I think we're going to use them in a moment, I'm pretty sure. And although the forceps didn't fully remove it, it did really help to eventually extract this. Now, because of the amount of swelling, it's hard to get much movement into the suction probe. I would really want to wriggle this and move the suction tip around to kind of peel and extract the skin, because the skin is attached, this outer peripheral layer, as you can see here, but there's not much movement available for me. So what I'm trying to do here is go behind that granulation tissue and bring that, and also that swelling. You can probably see that swelling just to the left of the suction probe, and behind that swelling the ear canal opens up again, so this plug is encapsulated into the swollen ear. So I'm trying to remove it out of the wider cavity. So I'm going all the way around, going to the bottom, trying to lift it up, but it's almost got a consistency of keratosis obturans. Now this isn't keratosis obturans, there's no remodeling. This is keratosis obturans happens when the skin fails to naturally migrate. This is different. This patient has impacted it. So I'm just trying to use the right angled ear cutting. There's minimal space. I just had to manipulate it in a way where we're not going to be touching the side canal walls, and I'm just trying to leverage this down so the tip of the hook is going into the wider part of the ear where behind the swelling. So just going back in. Although the hook didn't remove anything, it cut through some of the skin, which is hopefully going to allow me to suction some away. And just throughout the procedure, just making sure the patient was okay, which they were. They're obviously aware not to use cotton buds again. You can see some granulation tissue at the top. So as I'm peeling it away, that granulation tissue is also coming away. So granulation tissue is inflammatory tissue. It's essentially connective tissue that forms as a result of inflammation and trauma. And that connective tissue undergoes a process called neovascularization. It forms its own blood capillaries. So when you have granulation tissue in the ear, and it's quite common with a grade 3 keratosis obturans or malignant otitis externa, you have granulation tissue. If that connective tissue gets taken away or pushed up against, it ruptures these newly formed blood capillaries, so you do get some bleeding there, which then clears because it's got its own blood supply, this connective tissue. So using the forceps here, and you can see I can barely open the jaws, because if I open them any wider, I'm going to compress each of the jaws against each side of the ear canal. And that is obviously because of this inflammation. There's increased temperature in the ear, and therefore increased humidity. So some of that humidity is condensing on the lens of the endoscope. When you perform microsuction, it's not an issue, because when you suction, it reduces the temperature. Well, the tip of the suction probe is really cold, so all that humidity, instead of condensing on the lens of the endoscope, it condenses on the suction tip itself. So the forceps have helped there. I managed to remove some matted hairs and some skin. So I'm just going back in with the suction tip, and I'm just trying to peel it away. And although it's not coming away, I can see it peeling at the back, and that's very useful for me because it's telling me how dense and how thick this plug is. When your ear is this blocked, you just don't know where the eardrum is. This layer of skin that I was removing and wax, it may just be really shallow in depth. So we've got to be careful, especially with the forceps, because if you put too much pressure, you can make contact with the eardrum. But that's given me an idea. I know the eardrum I've got a bit of wriggle room there, because I can see the tail end of the plug peeling away. So it's giving me some depth perception there. So I've now decided to go back in with the forceps. I'm feeling a bit more confident of grabbing a bit more and pulling it away, knowing the eardrum is not directly in close vicinity. So that granulation tissue was just getting in the way, so I've just kind of suctioned that away for now. And there's some skin that's trapped here, which is forming part of the plug. You can see that's coming away. As I'm suctioning here, the ear canal is collapsing, So the strength of the suction is it's attracting all the fluid, all the swelling in the cells of the surrounding ear canal where it's swollen. So that fluid is getting attracted by the suction, is causing the ear canal to close in. So we're now 2/3 of the way in. You can see once more the canal is collapsing slightly. And this suction tip, as I said, it's got an outer diameter of 1.6. It's barely fitting inside the ear. If I was using the 18 gauge, it would have been even more difficult because it would have lacked the necessary suction power. Now, I still haven't got a direct view of the eardrum, but I did remove a sizable piece of dead skin there. And I can see some skin coming away. There's a bit at the base of the ear canal, so I'm just trying to lift this up. I think I'm trying to go to the top and trying to leverage it down because I can see it's attached to the roof of the ear canal. It may not seem like it, but we have removed quite a lot already. Initially, this plug was extending right up to that granulation tissue on the left. So I've probably removed half of it already because you can see a bit of distance now between the granulation tissue and where this wax and keratin is positioned. So I'm just going back in with the forceps and just about managing to fit that in. And these are the micro jaw forceps. So they've got a really slim profile. I think about 1.9 mil, so less than 2 mil. So again, the forceps didn't remove the plug of wax and skin, but it did remove some of the hairs, which then allows me to get a better suction grip. So I'm just lifting this up. So we are working in the tiniest and minutest spaces at the moment. And I know I can appreciate on the screen, although it is obviously narrow, but it's highly magnified. But you do have to remember, so that space we're working in is less than, well, it's about 1.6 mil. Apologies, I forgot to edit that blank space out. So still haven't got a full view of the eardrum. I'm just going in, working from the bottom, trying to lift up, trying to separate some of that skin, giving it a little wriggle. So I'm trying to go around in circular movements to help separate the skin, but once more, I'm limited of how much in my range of movement. Just using the forceps again. Just managed to extract a bit more. So the outer part of the ear, it's not really swollen, it's just this deepest region. There's some granulation tissue at the floor with some dead skin, so I'm just going to lift that away. I'll be very honest, halfway during the procedure, I just didn't think this was going to be possible. Patient would needed to go away and have this swelling reduced by taking some steroid ear spray. But as I mentioned, the patient just really wasn't able to cope. I see a lot of patients with a lot of earache, especially when they present with keratosis obturans, but I would say this patient was, this is probably affecting more them than any other patient really I've seen in the past who've come in with earache because of their impaction. And they just weren't sure what the doctors are going to be able to do because most doctor surgeries in the UK don't offer earwax removal, and if they do, they typically offer irrigation, which is not obviously permitted in this ear because of their swelling, and inflammation, and it wasn't really going to help much, if the truth be told. It probably would have made their symptoms worse, and then getting an ENT referral, you're looking to 12 to 18 months on the NHS. Depends which part of the country you're in. So I've just put some sodium bicarbonate drops in here, and now sodium bicarbonate drops, similar to hydrogen peroxide drops, they are water-based, and it's normally a cocktail of sodium bicarbonate, probably about 5%, and then you have like 30% glycerol, and it also contains purified water. There's sometimes some alcohol as well, which the sodium bicarbonate drops I was using just to have some alcohol, and the alcohol acts as a mild antiseptic. And similarly to hydrogen peroxide drops, sodium bicarbonate drops reacts with a carboxylic acid, and a carboxylic acid is contained both in sebum, which is the oily lipid secretion secreted by the sebaceous glands, and within the skin cells itself. And when sodium bicarbonate drops reacts with a carboxylic acid, it converts into water and carbon dioxide. And similarly to hydrogen peroxide drops, the water gets absorbed by the skin cells, causes the skin cells, the dead skin cells that are contained within the plug, they overhydrate, they burst, so it helps to fragment. It doesn't dissolve, it fragments it breaks the skin cells up, and the effervescence due to the conversion into carbon dioxide is believed to help to mechanically break down the plug. So sodium bicarbonate drops and hydrogen peroxide drops works in a similar way. They release water and they release a gas. The water helps to fragment the skin cells through overhydration, and the releasing of the gas creates effervescence, so it's mechanical bubbling, which is also believed to further break up the plug. The difference between the main difference though, sodium bicarbonate drops, it can sometimes over dry out the ear because it contains alcohol. So alcohol will homogenize with water, and because alcohol has a lower evaporation rate, it can tend to dry out the ear more so. And the pH level of sodium bicarbonate drops is it's mildly alkaline, whereas hydrogen peroxide is mildly acidic. And in fact, the hydrogen peroxide drops that I use, not often, it's something that I thought I'll try with this patient. It also contains a phosphate buffer, so the phosphate buffer helps to further increase the the acidity of the drops. Our ears are mildly acidic, and the acidity in the ear helps to prevent more harmful bacteria from colonizing and leading to an ear infection. Some of the more pathogenic bacteria are neutrophilic, so they thrive in more neutral pH levels. So sodium bicarbonate drops, because it's more alkaline, it can increase the pH level, making it more neutral in the ear, whereas hydrogen peroxide can help to maintain that acid mantle. So we're nearly there. You may not be able to see it yet because of the swelling, but the eardrum is now visible, and of course it's inflamed. This is impacted right up against it. I'm just trying to remove some skin adjacent to it. I don't get all of it, but I'm happy with what we've managed to achieve here. You can see all that swelling to the right. So there's no active bleeding there. So all that kind of blood before you were seeing was just granulation tissue. There's no laceration. We haven't caused any trauma. We haven't lacerated the ear canal or perforated the eardrum. So just a bit of skin on that eardrum now. I could see the eardrum flexing slightly as I was suctioning. I'm just getting some skin anteriorly just so we can get a better view of the eardrum on that side. Just want to make sure there's no trauma to the eardrum, because obviously the patient did So he was using a cotton bud. So that's the eardrum there. So it is intact. We did a pressure test as well, tympanometry. So this patient was over the moon, as one can imagine. I'm very grateful. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.